Welcome, my dear friends. Myself, Professor Dr. Rajendra Raghuveer Deshpande from Pune, Maharashtra State, would like to welcome you all in my Ayurveda Academy YouTube channel. My dear friends, as you know that I am MD in Ayurvedic Medicine and MD in Ayurvedic Physiology. For paid online consultation, you can definitely WhatsApp on 922-6810-630. My dear friend, this is the series going on related with the clinical discussion, clinical examination of the different types of complaints of the patient. So today's the one patient of 32-year-old male patient come to the doctor. Patient says, "Doctor, I am getting the pain in the right lower abdomen since last 3 days. And doctor, please check it very carefully because you see that this is the third time that I am getting such an attack during the last 6 months. Third time I am getting the lower abdominal pain. I don't understand what is the problem." Oh, doctor starts thinking about this case, pain in the right lower abdomen. So I have the differential diagnosis. I have to think 2 or 3 or 4 diseases or the problems. First came into my mind is appendicitis, because right lower abdomen is a peculiar site of appendix, and that particular appendix organ gets infected and inflamed, and that is called as a appendicitis. Many people think appendicitis, admit, operation. No. There are 2 or 3 varieties. One is acute appendicitis, another is also chronic appendicitis. So I am expecting something like that because this patient is having third attack during the last 6 months. So this may be the case of chronic appendicitis. But of course, I have the another things in my mind. For example, I must check whether this patient has amoebic colitis. You know that amoeba and the giardia, these are the parasites. Because of the contaminated water, they enter into the body and the patient is suffering from that particular dysentery. Okay, so amoebic E. histolytica is a name of organism that particular causes this dysentery. So I must rule out the amoebic colitis. And third thing which was in my mind, because you know all these things are coming in a fraction of second. Although I am explaining you, but all the things like a computer, tack. Huh? So third thing is a ureteric colic. Ureteric colic. Colic is because of the spasmodic pain because of the stone in the excretory system. Ureteric stone, renal stone. And last but not least, I have to check whether the patient is having ileocecal tuberculosis. Yes, many of you know only the TB is of lungs. No, my dear friends, no, not at all. Of course, the lung TB is the most common variety. Pleural effusion is also common, but there can be the TB of the abdomen organ, TB of the vertebrae or the bones. So just keep in mind that TB can occur any part of the body. Okay. So let us check with the patient, and as usual, the history taking is the most important part during our clinical examination. So first, my question to the patient, is this pain is like a colic, spasmodic and intermittent, or is it a continuous pain? No, doctor, it is a little bit moderate type of the continuous pain. I don't get any attack or the spasmodic intermittent here. It is a continuous pain. Okay. Do you have any fever in last 2-3 days or the vomiting? Yes, doctor. Yesterday or the day before yesterday, I also was feeling like tired and fatigue and malaise and little bit feverish. Yes, I have not checked with the thermometer, but I think I have a fever. Okay. Yes. Yesterday morning, I had that particular vomiting and even the day before yesterday, I had once a vomiting. Oh, I see. So here Actually, the patient complained only of the lower abdominal pain, but I found the three things together. Which are the three things together? Number one, pain. Number two, fever. And number three, vomiting. So these three things is in medical language called as a triad. Three things. Triad of pain, fever and vomiting is a common thing in appendicitis. Remember, in appendicitis, three things come together: abdominal pain, fever and vomiting. So my diagnosis is more over, yes, chronic appendicitis patient. But let us ask another few questions. Oh, see, my friend, do you have the painful micturition, urination? That is, in our medical language, we call it as a dysuria, painful or burning urination. Or does it has a very dark colored or the red colored urine? Oh, no, 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 no. Doctor, no, nothing about urine. No problem. I am normal urine, no pain, no burning, no discoloration, no, nothing, doctor. Okay. So here the ureteric colic is a less possible thing. No ureteric colic. Again, my diagnosis was, yes, chronic appendicitis. Next, I asked, do you have or did you have in the last few weeks any loose motion with the mucus or sticky type of the stool, a little bit straining? No, no, doctor, no problem of the stool. It's okay. Nothing to be another thing or any change in my stool. Is it okay? Okay. So I ruled out the possibility of amoebic infection or amoebiasis due to the entamoeba histolytica. Okay. My friend, tell me, how is your appetite? Actually, see, a little bit less. I am not feeling that much hungry in these few days. Okay, okay. Again, for you, understanding, in amoebiasis, appetite is always remain okay, good, but in appendicitis, because it is an infection, it is a fever. So in appendicitis, the appetite is reduced. So my provisional diagnosis is better and correct. Okay, but I have to go forward and I have to do the clinical examination. As usual, I ask the patient to lie down on my examination table. Again, take the legs fold, that means fold in the knees, take the legs near to the abdomen. I am standing on the right side of the patient and I start my inspection, palpation, percussion and auscultation. Okay. So this is the clinical examination after my provisional thinking of chronic appendicitis. When I palpate the whole abdomen, I found that there is a localized tenderness around the McBurney's point. Try to understand. I have checked the abdomen. McBurney's point, you can see in the picture, McBurney's point. There is a tenderness. When I press it over there, patient is grumbling, screaming. He is getting the pain after touch. That is called as a tenderness. Pain is a subjective matter. Tenderness is a sign. So McBurney point tenderness going the indication of, yes, appendicitis. Then I asked him to turn a little bit, get up on the bed, and from the back side, below the sternum, I just press it. But I found that there was no grumbling, screaming. That is called as a no renal angle tenderness. Try to understand. No renal angle tenderness. So tenderness, if it is tenderness, then that can rule out the ureteric colic. So now my thing is only either it is a chronic appendicitis or maybe amoebic colitis. Okay. Next, I am going further and checking my abdomen, and I am pressing the whole abdomen, palpating slowly and steadily. And I found that mild tenderness was there also in the epigastric region. epigastrium above the umbilicus in the central part. Actually, this epigastric tenderness is also a little connected with appendicitis. Okay. Now, okay, I have to rule out the amoebic colitis, so I continue the palpation. But actually, this patient doesn't have any tenderness other parts. But if I found that tenderness is also present right side and also on the left side, then it can be amoebic colitis. And you see that the treatment is totally different. Amoebic colitis can be treated by, previously we used to use tablet Metrogil or metronidazole, but now the commonest is a tinidazole. Tinidazole one has to give. Okay, so slowly and steadily we are confirming our diagnosis. Try to understand, if now imaginary, all the other things are imaginary for you. If fullness or if I find any lump on right iliac fossa, lump or the fullness, if the patient is having low grade fever, evening raise of the temperature for 2 weeks, 3 weeks, if the patient is complaining of weight loss, then I must think of ileocecal tuberculosis. First, I have to think pulmonary tuberculosis, but if the patient is not having cough and sputum, then this particular right lower abdomen, tenderness, lump, fullness with additional low-grade fever, weight loss, then I must think of ileocecal tuberculosis, which is not in this patient. Now, this is a male patient, okay? If by chance this is a female patient, again imagination, female patient, okay, and complaining right side lower abdominal pain, okay, that is a right iliac fossa, then the lady doctor should do the gynecological examination. Gynecological examination. The lady doctor can ask to this particular lady patient about her menstrual history to rule out the problem of dysmenorrhea. That can give the cramp-like pain in the abdomen. Dysmenorrhea, that is painful menstrual cycle. Then if there is a tenderness, then lady patient, then doctor should think of pelvic inflammatory disease. Pelvic inflammatory disease, that is PID. Okay. And sometimes right tubo-ovarian mass, there may be some mass-like swelling in the fallopian tube or in the ovary. Sometimes it can be early pregnancy. Then that means just 1, 2, 3 months are there. Then I must think of ruptured ectopic pregnancy. Try to understand, these are the cases. Ruptured ectopic pregnancy can be also differential diagnosis. So I have explained you, if the male patient, then my diagnosis is a chronic appendicitis. Okay. Now, what I or any doctor can do. For example, if we are not sure about our provisional diagnosis, then some 3 days course of tinidazole can be given, and if it is over, pain and everything, then okay, then it can be amoebic dysentery. But tenderness persists, then definitely it is going favor for chronic appendicitis. Try to understand, basically most of this diagnosis is a clinical diagnosis. Now what else investigations the doctor can do? The doctor can do the barium mill, then you can do the USG abdomen ultrasonography, is very simple test, non-invasive, no painful. Also I can do the hemoglobin, then I can do the CBC, complete blood count, especially WBCs. White blood cells are like soldiers. So whenever I am suspecting infection, WBC count will be raised. Okay. For example, normal count is 4 to 11,000. If more than 20,000, 15,000, 25,000 per cubic mm, then that indicates the infection. Then I must check the stools, routine examination, especially for amoeba and giardia, that is entamoeba histolytica or giardia lamblia. These are the names. Then I must check also urine routine examination. to, of course, the check for albumin. Then I can check for sugar for diabetes mellitus. I can check for especially microscopic examination is important because I am suspecting sometimes stone. In the stone case, renal stone, ureteric stone, the urine will show the red blood cells, mild or moderate type of the quantity, that is like a hematuria, and also lot of or abundant crystals. Urine microscopic examination. There are three types of examination: urine physical examination, urine chemical examination, and urine microscopic examination. Together it is called as a urine routine examination. You understand? Okay. Then one doctor can do the, in addition to the USG, KUB, kidney, ureter, and bladder. This type of the X-ray can be done to check for the stone. Now, once our chronic appendicitis, this diagnosis is a confirmed, then better way, we doctors, general practitioners, can refer this case to a typical abdominal surgeon, and before sending or during the process of referring, we can advise the patient to take the tablet Ciplox TZ, that is ciprofloxacin and tinidazole together. Ciplox TZ, one in the morning, one in the evening for 5 days before finally advising surgery. Even we do the planning of surgery, surgeon also can advise the same thing. Antibiotic cover should be there before the surgery. So my dear friends, today we have discussed the male patient of 32-year-old came for the complaining of right lower abdomen, and our final diagnosis was chronic appendicitis. I hope you are enjoying this type of the clinical discussions. So I wish you all the best. We will see with the same type of the different problems in the next video. Till then, you can enjoy the life, take precaution, and see you in the next video. Thank you very much. All the best.